I don't have any interest, but this is my disclosure. I found it in 1987, 35 years ago, the first multidisciplinary pain clinic in Spain, in Barcelona. Although I come from Madrid, you know the rivalry between Madrid and Barcelona, like in Milan and Rome, or human being is always the same. What's innovation? Innovation is not creation. Creation is to conceive something, whatever it is, from nothing existent. But innovation occurs when an actionable an organization identifies a key challenge. The key challenge is determined to improve upon that challenge or to eliminate that challenge entirely through new processes of tools. In fact, is to look at a phenomenon, natural phenomenon, from a different point of view. And that is innovation. It's not creation, I repeat. Regenerative medicine started, in fact, by the end of the 19th century in the great medical school of St. Petersburg. And some of them moved to the States after the period of the revolution, but it still remains there a great school. And it involves delivering specific types of cells or cell products to diseased tissues or organs, where they will ultimately restore tissue and organ function. So regenerative medicine now became a great area because we don't know the limits, in fact. And we also discovered new products, PRP, and different solutions, whether or not leukocyte-rich, platelet-rich plasma is better, and for what conditions, for acute, for chronic, all this has to be much better known, and we are in the process of doing that. Next one, please. I don't know if it is. Okay. I'd like, first of all, to compare the differences between adipose tissue-derived versus bone marrow-derived stem and stromal cells. Because, for instance, Professor Hennig studied and followed on with marrow bone, because at that time it was supposed that the stem cells were, it was, well, the place for the most important formation in the adult of mesenchymal stem cells and regenerative cells. In fact, MSC are found in virtually all organs of the body. And they were discovered by Friedenstein like 40 years ago. And then maybe Hennig was the first who applied it in clinical setting. Subsequently, but it was later on, of course, when after these essential and primary discoveries. Subsequently, mesenchymal stem cells have been isolated from various other sources with adipose tissue. When later on Kaplan and his group, then Diego Correa, and they described the pericytes, or, well, they call pericytes to the mesenchymal stem cells surrounding and embracing the vessels, and they are essential for the angiogenesis of adipose tissue storing. So both of them share many biological characteristics. However, there are some differences in their immunophenotype, in the transcriptome, in the proteome, and also in the immune activity as regulators of the immune system. Despite the minor differences between the populations, adipose tissue or adipose stem cells seem to be as effective, at least, as bone marrow MSS. In clinical application, in some cases, may be better suited than bone marrow. The mesenchymal, which is important to use the terminology because there is some confusion, and usually even in certain symposia or congresses, we detect that confusion. The Mesenchymal and Tissue Stem Cells Committee from the International Society for Cellular Therapy proposed the marrow-plastic adherent cells generally described as mesenchymal stem cells that should be retermed multipotent mesenchymal stromal cells, while the term mesenchymal stem cells should be reserved for a subset of these cells that show stem cell activity by clearly stated criteria. It was led this committee by Horchwick in 2005. So, mesenchymal stem cells reside in the connective tissue of virtually all organs, including adipose tissue, and constitute a whole complex system diffused through the body. And this research has been very strong and with different groups during the last decade. Mesenchymal stem cells has also been isolated from human placenta, including fetal and maternal origin, umbilical cord blood, umbilical cord and Wharton's jelly, amniotic fluid, amnion, and various fetal tissues, including blood, liver, spleen, bone marrow, and lung. Then some remarks for finalizing this small chapter regarding adipose and bone marrow that are probably the best characterized and most commonly used in clinical practice. Although there are some differences between bone marrow and adipose in their gene expression profile, the angiogenic potential and secretion, that maybe is the most important that we look for in the clinical setting, and secretion of factors preclinical and clinical data support the use of both MSC populations in various clinical applications. For instance, in Crohn's disease, now there is a very well advanced in phase 3 in Crohn's disease using adipose tissue. So, in summary, we can use mesenchymal stem cells, although, for instance, our friend Arnold Kaplan says medicinal signaling cells. Okay. He liked that word. We respect it. And mesenchymal stem cells, and also he says pericytes, in fact, it was the great innovation for us, I mean, as clinicians, while we are doing these therapies in the spine. Platelet-rich plasma and amniotic-derived products. We are not using, in my clinic, amniotic-derived products. We are using PRP with leukocytes rich for chronic pain conditions. That's an important aspect. And then the mesenchymal stem cells. And now we are coming into the third phase, which is storage, culture, and cryopreservation. It took for us 3 years of pandemic. We stopped our evolution. We had to stop because there was no other possibility. We are using South Korean technology, and whether we were using American technology is the same. I mean, we couldn't travel back and forth. So in regenerative medicine therapies, the evidence is very little yet. So we need many studies in every field. And these limitations is because the randomized controlled trials are very poor in quality. And the findings of systematic review and single-arm meta-analysis shows that mesenchymal stem cells and PRP may be effective in managing discogenic low back pain, radicular pain, facet joint pain, and sacroiliac joint pain. Maybe the disc is the most important together with the treatment of complex degenerative spine disorders. And the disc was the subject of very large research conducted by Mesoblads, but the findings were certainly, they didn't, I will go later on, but they found it very controversial data. So for low back pain, for chronic low back pain, there have been also several cell-based therapies, injection of medicinal signaling cells, mesenchymal cells for the bone, marrow, or platelet-rich plasma. However, there is only emergent clinical evidence to support the use at this time. If you compare the evolution of a normal disc, you can see in grade 1, this is like a baby, the disc from in the childhood or the newborn. And you can see how naturally it comes down to the grade 5, and these cells are very few, and many are dying or unhealthy. And it is because the disc receives very poor vascularization. And the innervation comes from the outer annulus and maybe branches of the sinovertebral nerves. And just because there are more cell presence does not mean that they are necessarily healthy. Maybe senescent, maybe are not viable metabolically. So 25% of cells in herniated discs are senescent. So the thing of and the challenge for this reparation is really something so important. But when we started 45 years ago to remove the disc and to throw it away, only a few of us understood that that was medieval medicine. I mean, it is like to take off an abscess and then to put it away. But the art will be how to repair. And for that, we need tools. What type of tools? So we are in this type of, in the shadow of regenerative medicine. It's difficult sometimes to see the light, and we have to go little by little and improving and based on evidence then to implement new therapies. As you can see, the cells dictate the structure and the organization of the matrix, and this collagen is so difficult to repair because to my patients I say always, listen, you have to compare a lesion of the Achilles tendon with the disc. When you listen in the TV that a football soccer player is lesion the Achilles tendon, you can assume that this player will not play for as long as 1 year. So, and the disc is the same. When we, whether with one therapy or another, we intervene in the disc, then we know that it will take months to heal. What are the new therapies? Synthetic disc molecules, growth factors, tissue engineering, genetic engineering. Well, all these are, and also cadaveric allograft. But all these therapies have been very, they gave us much frustration, and were not enough at all to define a clear line of clinical therapies. So these are the stem cells source identified that I mentioned before. The point, the limiting point, the most important limiting point is the ethics, because embryonic is not accepted at all. I heard even that now adipose mesenchymal cell therapy, someone told me that in the United States is completely forbidden now. although it is autologous. Of course, allogenic is prohibited, isn't it, Anu? No? And then, what is a stem cell? Because although it is forbidden because of the big pharma is lobbying, we know that, because what they want is to give you a pill, no, or to inject the small cage, and then to repair the structure, and that is the reason. This is an economical reason. In Europe, fortunately, we are not so limited. We can use autologous, but I would never use embryonic. I mean, because ethically, I think it's not acceptable. And this is stem cells, as you know. We come from the totiprudential, multipotential. So there is a graduation, of course. And what we are using, adipose tissue, which is the most frequent for a interventional pain doctor. Then we are using a pluripotential cell. So these are the sources of regenerative agents. And what cells should we use? Autologous? Yes, I think this is really the field that we have to develop. Regarding intervertebral disc, there are some human trials. Maybe the most important is the Mesoblood study. And to make it simple, I'll tell you that it was a big frustration when they showed that a substantial number of these were repaired, but mainly with 8 million of adipose tissue, of mesenchymal stem cells. And that results were superior to those series of patients that used 16 million cells. So everybody thought, what's going on here? We thought that the more cells, the better results, but it was not like that. Coming back to the PRP, that maybe for the Americans is more interesting now. Anyway, I don't mean that mesenchymal stem cells need more research and more data to apply it safely in a clinical setting. No, I think that in Asia, for instance, or in Asia, especially in Japan, the FDA published some years ago that has been also copied by the South Koreans, and they're using allogenic as well in certain cases. But it's not a prohibition, a complete prohibition, and for sure autologous. What is PRP? Well, it's a sample of plasma with a platelet concentration 6 to 8 times greater than a physiological platelet concentration that can be found in the whole blood of healthy individuals. That is nothing new, because from the 50s, it was used in dermatology, in maxillofacial dentistry. They were very much advanced. In fact, dentistry is curious that it is a specialty that gave a lot to medicine as well, because they were the first who started with the titanium for implants, and then the orthopedic surgeons and neurosurgeons took the idea, and we started to implant this type of metals. The evidence is that despite extensive use of PRP for more than 3 decades, I would say now 6 decades, there have not been enough prospective, randomized, double-blind control studies. And when we started to use it in my clinic, we first injected PRP with leukocytes, LR-PRP, in the epidural canal. There was no any reference in the medical literature, up to our knowledge. And then, well, we started with some, well, with much prudency, because in fact it was as the first orthopedic surgeons started to inject corticoids in the epidural canal. We thought, well, it's biological. We did some testing with veterinary, with dogs specifically, and we saw there was no reaction. So we moved into the human clinical, and then we started with large volumes, and we started with a concentration of after 60 milliliters, and then we are using now protocolary 120 milliliters, which is around, out of the centrifugation, around 50 milliliters. We think that in complex regenerative spine, it's important the volume, and also not for washing it up, but just for let the product, the solution, to be effective. And usually we let the patient stay in the recovery for 3 hours at least. And then, then next stop was the comparison with corticoids. You know, all of you know that in platelets are many growth factors, coagulation factors, addition molecules. In my country, for instance, it was the confusion that they call PRP growth factors. But, and I'll tell my patients, the platelet is not nucleate. It has so many products. It has a function of regenerative, and we even give some information in order to let them be much more informed. And so out of these 1,100 substances, so what we know is that they play a role because it's a part of the blood that is precisely in charge the tissue reparation and the bone healing. So using the same scheme, we started with the therapy. This should be the alpha granules of the circulating platelets. And we know the activity of these platelets: cell replication, angiogenesis, tissue granulation formation, and growth of extracellular matrix. This is the way we collect it in sterile conditions, always in the surgery room. In fact, we built up a small laboratory in the surgical area to manipulate whether the PRP or the cells, the adipose cells. So in order not to let go outside the area to another part of the clinic. And then, well, this is, it can be consulted if you need more details in the paper. We already published last year, which is a randomized. This is the small laboratory when we use inside the clinical, the surgical area. And then with the sterile conditions always. And then we use, this is not a secret. I mean, there is not a fixed rule. I mean, some groups are using an amount of minutes and an amount of RPM. We are using typically 40 minutes and 1,800 revolutions per minute. This is and then we get, the solution we get has leukocytes and platelets. Then this is what we get typically, you see, with 2 vials. Then we inject around 50 milliliters altogether with ioxol, with contrast, which is very important. There is no any interaction between the contrast and the and the PRP. There was for the discs, for instance, I know that our colleague Sudhi Diwan we'll talk about. So I'm not go through PRP intradiscal, but it is ready. This is our study with Yu Chuan-Tsai, Professor Yu Chuan-Tsai in Kaohsiung now, and also in Tainan first, no, now Kaohsiung. And so we conceived together, but the study was done in my clinic, because our aim was to compare the efficacy of platelet-rich plasma and corticoids for complex, chronic, degenerative spinal pain, both as being complex, chronic. Well, there are many elements altering the structure and also acting as nociceptive of neuropathic generators of pain. Usually the range of age is quite high, but we also have some other patients. And of course, patients, they like the concept that less is more. So if you can do that, first let's try with that, and we'll see if I will need a more invasive and more interventional therapy. That was the objectives, and the study design is a prospective randomized control open blinded study. We took 2 groups, 25 and 25, and we measured with analog scale, a visual analog scale, and SF36. And we did a follow-up to 6 months. Now already this follow-up up to 2 years is not published yet. And this is, the surgical room where we, in our clinic, which is an ambulatory surgery center, and how do we prepare the patient. That is absolutely essential. This technique is very safe because as we are injecting leukocytes, then there is anti-infectious agent also acting, so it's quite safe. Sometimes we get some problems with the localization of the caudal, as all of us. I mean, not always is easy to reach the caudal, the hiatus sacral. And then I said before about the characteristics of the technical issues for obtaining the ALR PRP. This was our mean age, I told you, 61 plus minus 12.6. They're comparable completely. And with LR PRP a little bit older. The range, so you can see from 36 to 98, because more and more we are visiting elder patients, and I think this is a common characteristic in all of our clinics. So female were 15 and 14, 15, 10, and 14, 11. Female, as we all know, also pues, they perceive in a high degree or more than men because of the genetic, of their genetics, chronic pain and acute pain as well, maybe. These are the general study. I will not go through because I will show you now what happened with the evolution of the, this is a typical X-ray of how the contrast with the LR-PRP advances in the spine. And this is the group. Initially, the corticosteroid group does better. That group does better initially. But through the time, but you see the outcomes at 3 months, while comparing them, are much better at 3 months, and 6 months much better. I will not mention about what we are finding now after 2 years until a paper is released. So no significant difference was shown at baseline between the two groups, and there were no complications at all. This is a very safe technique, and the scores were lower in the LR-PRP group at 3-6 month follow-up. This is very important because the conclusion is that autologous PRP is an ideal new injectable biological drug for the application of epidural caudal root injection to treat spinal cord pain conditions of non-malignant complex origin. Both PRP injection and local anesthetic corticosteroid injection were determined to be effective, easy, and safe enough for the treatment of this condition. We can conclude that, therefore, autologous PRP may be a superior treatment option for its longer duration efficacy. And the study, finally, suggested that progressive healing could be playing a significant role in the clinical improvement of PRP group, based on the finding that the PRP group improved progressively at the 1 and 3 months follow-up visits in comparison with the corticosteroid group, which only showed short-term clinical improvement followed by a decline. We all know that because these are what we find when we were treating patients just with corticosteroid. That was the reality. Now, I'm bringing. I brought this data, maybe for some of you, if technology is available. Technology is not so expensive, so the most important point that I should mention is about sterile, and it has to be well ready with fluoroscopy is essential, and also, of course, an OR. You can see that the key areas of promise in research and innovation regarding spine surgery is going technology innovation by means of increasing use of image guidance, robotic technology, but not that much, because the orthopedic surgeons put much emphasis on robotic, thinking that to work with a robot will do everything. And then when they tell to the patients, I will be operated by a robot, which is much easier, because they think this is something absurd, that it should be also demolished. This concept is not robots, okay, are good for some implants, but just for that. I mean, it will not replace the surgeon for sure. And the use of biologics. So, and this is a point very important, the disc repair and the enhancement of spinal fusion. So promising research, we have to go further with the biological solutions to spine disorders. The reversal of this degeneration, for that we should make a prompt and early diagnosis, because this represents a unique therapeutic target for anti-catabolic and pro-anabolic solutions. Annular repair is a challenge for both post-discectomy repair and annular disruptions. Maybe post-discectomy repair will be a poor remnant of the old surgery, except in traumatic cases. This is very desirable, especially those who were trained in the classical therapy who was just discectomy. And the more discectomy, the better that was. So we try to mimic nature. Thank you.